So with that being said, I want to make sure I talk a little bit about central sleep apnea and OHS. I know it's getting a little bit late, but a 36-year-old man without significant past medical history is referred for symptoms of fragmented sleep, sleep maintenance insomnia, daytime sleepiness, Epworth is 13. His wife has observed the patient has apneas throughout the night, but denies any snoring. Okay. Patient's sleep disruption and sleep disordered breathing occurs more during the first half of the night. I put that in a little red right there. Seems strange because most obstructive apneas happen where? Right, kind of in the second half of the night, closer to the morning, because we get a little more REM sleep at the time, and improves as the night progresses. Go figure. Central sleep apnea actually does improve as you approach the morning because central apneas really are better in REM compared to obstructives, which are worse. Symptoms are not positional, kind of goes with central apneas, and are not associated with awakening related to shortness of breath. He denies any cardiac disease, chest pain, or chronic pain syndromes. Okay, cardiac disease, Sheen-Stokes, chronic pain syndromes. Maybe he's on opioids and is having what they call a Biot's breathing. We'll talk about that word in a second. No restless leg symptoms or depression. He has no history of stroke or other neurological disease. He denies dyspnea on exertion or lower extremity edema. No meds, no allergies. He lives in a Midwestern city at an altitude of 1,000 feet. Is this going to be high altitude central sleep apnea? I don't know. Physical exam BMI is 24. Vitals are normal. They did some tests and labs. Spirometry is normal. The echo is normal. ECG is normal. A UTOX looking for, I guess, opioids is normal. They do an arterial blood gas, and it looks like the pH is above 7.4. So the patient's slightly alkalotic. CO2 is below 40. So this is a respiratory alkalosis. And the PO2 is good at 100, and the bicarb is solid at 24. So kind of a smidge respiratory alkalosis. They do a split night polysomnography was performed, and characteristic sleep disordered breathing findings from baseline and CPAP portions of the study are shown on the next slide. So what happened during the baseline? What happened during CPAP? So this is going to be the baseline right here. And this is going to be indicative throughout the whole polysomnography diagnostic, but it looks like there is no flow, no effort, no flow, no effort. This is central apneas. So then they did the titration portion of this, and they put CPAP on this patient, and what a surprise. Central apnea, central apnea, central apnea, central apnea. So it really didn't do anything. So where are we going with this? Here's the baseline in the CPAP titration. The AHI at baseline was 50, and it looks like almost all of them were central apneas. The central apnea index was 40. The obstructive apnea index was only 5. And during the CPAP titration, there was a lot of treatment-induced central apneas. So not a surprise that that occurred when they put CPAP on this patient. Which of the following is the most likely diagnosis? All right, so is this going to be central sleep apnea from high altitude? What do you folks think? No, it's not fair because I'm the pulmonologist, and I think about high altitude. You got to give me at least, 6,000 to 8,000 feet. 1,000 feet is just not going to cut it. But there is such thing as high altitude central sleep apnea, which is not this. Is this going to be Sheen-Stokes respiration? Of course, it'd be nice to have some history of heart failure. We could measure out how long the cycle length is going to be for central sleep apnea. But this doesn't look like Sheen-Stokes with no risk factors. Is this going to be treatment emergent centrals, choice D? Probably not, because the baseline diagnostic showed central apneas, and we rolled out opioids because of the urine tox. So you're kind of bullied into picking one. This is primary central sleep apnea. The correct answer here is what? It's C. And this is going to be definitely a diagnosis of exclusion of a rare thing, which is central sleep apnea. And a lot of the buzzwords on here is, please remember that we tend to see most of central sleep apnea in both N1 and N2 sleep. It usually resolves in REM sleep. So, it's important to think there's no positional component when we talk about central apnea. So other things to think about. So, oh boy, this question is for the goat. I mean, what does the goat stand for? It's not a mammal that's raised on the farm. I'm a big sports person. So it's called the greatest of all time. So that's each and every one of you listening today. Who wants to be the greatest of all time? 47-year-old corporate executive without significant past medical history has just undergone a complete physical and has been found to be in excellent health and referred for a polysomnography based upon complaints of fatigue and witness apneas during sleep. He takes no regular medications. A summary of the results of the first portion of the PSG are shown. I'm going to show those in 1 second. And a trial of CPAP between 5 to 15 centimeters of water during the later half of the night is unsuccessful in improving the abnormalities. So let's look at the baseline. So total sleep time is 178 minutes. It seems that patient had N1, N2, and a little bit of N3, 2%, but no REM. And the overall apnea-hypopnea index was 38.6, but look at this. The central apnea index was what? 25.8. So this is definitely going to be central sleep apnea over here. So no wonder the CPAP didn't work at all in these patients. So in someone who has central sleep apnea, oh boy, which of the following is true with regards to this patient's most likely diagnosis? So which of the following is true with central sleep apnea? So let's do this. The disorder is likely to worsen during REM sleep. What do you folks think about that? Is central sleep apnea going to worsen during REM? I said it 1,000 times, it improves regardless. So it's not going to be a bi-level spontaneous mode is effective for therapy. No, probably wouldn't pick that. Why? You need the timed, the T, because in central sleep apnea, you're really not going to initiate breath. So it's going to be important to have the T in there. So A is wrong, B is wrong. C, low dose hypnotics is likely to exacerbate the disease. This is not obstructive apnea. These are central apneas. And in fact, even though this is off-label, many sleep specialists, such as myself, will say that, low-dose hypnotics may benefit some individuals with central sleep apneas to prevent those multiple arousals and awakenings, kind of blowing off the CO2. But this is definitely off-label use, but it definitely wouldn't make it worse. So I guess I'm kind of bullied into D, but what is D? The addition of supplemental oxygen during sleep may decrease the frequency of central apneas. That's actually right. Of course, when we treat these patients, we may give them CPAP sometimes, and many of you are like, why do we give CPAP for central apneas? That makes no sense. And I agree with you, but maybe some of these apneas were obstructive and you're treating those. That's why we think about it. If they don't tolerate, CPAP, we may add oxygen to it. And many of you are like, why? Because what happens, you want to stabilize the oxygen. And it really, I guess you could give CO2, but that sounds kind of weird to make someone breathe in CO2 to stabilize it. But you give them some oxygen. In theory, it stabilizes it so you won't have these swings of hyperpneas and hypopneas. So of all the answer choices here, the answer is D. And each and every one of you, I know, got it right. So all you are the GOAT. And I just am getting older and older. So I don't know if many of you enjoy basketball or know who this is. This is my idol. I grew up loving Michael Jordan. And to me, he will always be the GOAT. So we talked a lot about central apneas over here. And we said the right answer is giving that supplemental oxygen, especially if they don't tolerate CPAP of these individuals. And we'll talk more about therapy in the next slide. So 65-year-old obese male presents for the evaluation of daytime fatigue and loud snoring. He reports difficulties in maintaining sleep during the night with the need to urinate on awakening. History of diabetes and hypertension. In a review of system, he has orthopnea, so he can't lay down flat. On exam, an S3 is heard. An S3 is a diastolic heart sound. It's an early diastolic heart sound, indicative of a fluid overload state, and he has lower extremity edema, so he screams heart failure. And they do an in-lab PSG over here. And what am I looking for? Well, I see pressure, and I see the effort, and I see flow. And what do I see here is there's going to be no flow and no effort. No flow, no effort. No flow, no effort. No effort, no flow. These are central apneas. It has that kind of crescendo, decrescendo type look to it. So it kind of looks like, I don't know, Sheen Stokes, And based on the PSG tracing, which of the following tests would be most appropriate to perform next? So Sheen Stokes can be associated with the heart, can be associated something with the CNS. MRI of the brain. Well, I think on your boards, definitely for sleep, they're going to talk about Arnold Chiari malformations, and some of these Arnold Chiari malformations can be associated with central apneas, but I didn't really get that from this patient, so I think MRI is a little overkill right now. Echo, cheap, non-invasive, especially a nice little transthoracic to get the ejection fraction. ASV titration, definitely not until you figure out what's going on with this echo. A tilt table test, only if you don't like the patient, just joking. But this is not a syncope workup, you know what I mean? And I think going to the cath lab is a little aggressive. Let's just get an echo first because you are suspecting Sheen Stokes. So I would pick what? B. Outstanding. And I even put this here. It's if you suspect an Arnold Chiari type 1 malformation, we see that here's the herniation back here when we talk about the cerebellum. And I know that's a classic on the sleep boards. So second part to this question, based on the PSG, if you forgot what it looks like, it's this over here. Which of the statements is most correct regarding this patient's congestive heart failure? So in this patient who probably has congestive heart failure, I'm giving that diagnosis now, will oxygen therapy improve long-term survival? Just based upon, just in general, no. When we talk about survival for CHF in itself, of course, there's going to be drugs that improve survival. There's devices that improve survival. But no, just giving oxygen won't improve long-term survival in these individuals. Having Sheen Stokes will give you an increased mortality. I like that one. I like that one quite a bit, but let me read the other ones. C, this patient with Sheen Stokes has a decreased ventilatory response to hypercapnia. Not really. In these individuals, when they are having a high CO2 finally, what happens? They just are breathing very intense, and they have these really big breaths that look like this, and that's where they blow off the CO2 all the way. And all of a sudden they're not breathing for a while, the CO2 gets up, and all of a sudden they start breathing. So if anything, it would have an increased ventilatory response, not decreased. So C is wrong. And the patient has an increased CO2 during wakefulness. One way to categorize central apneas are those that are hypercapnic and those are eukapnic or hypocapnic. Sheen Stokes, which this patient has, is usually associated with a normal to low CO2. So it's opposite. So the right answer here has to be what? B. Outstanding. And I just wanted to mention, for people with CHF, why are they having that really big hyperpnic responses? Because they have what's called an increased loop gain. So on your boards, we have an amazing central sleep apnea section that's taught by an amazing physician, and she really goes into depth when we talk about the loop gain, okay? And it's also important to know cycle length for Sheen Stokes respiration is greater than 40 seconds compared to primary central sleep apnea, which is less than 40 seconds. That was on my sleep board, so I hope you remember that for your boards. So I'm going to go a little bit quicker over here because I'm looking at the time. I'm like, wow, I just really can't stop talking. But central sleep apnea, though rare, is categorized in two broad strokes. One is going to be those who have a elevated waking CO2, so they're going to be hypercapnic, and they're going to have a decreased ventilatory response to hypercapnia. And what causes this? One could be neuromuscular diseases. I list a bunch out there: ALS, myasthenia gravis, muscular dystrophy. And the other is chronic opioid use. And I put all the pearls down here they're going to ask you on your boards. So when you take opioids, they work on the mu receptors in the pre-Botzinger complex. Can't believe they asked me that on the board, so please remember that, which is the neural network responsible for inspiration during the respiratory activity in the brainstem. You get this breathing pattern called ataxic or biotz respirations, and this was surprised during non-REM sleep, like most central sleep apneas. And the most important risk factor for getting this ataxic biotz breathing is the dose of morphine. The higher the dose, the more chance of getting it. And the one I missed on the boards is and people are going to be at a higher risk for developing this will have a normal to low BMI. I thought it was always going to be the people with the elevated BMI, and I totally was wrong about that. It's people with a low to normal BMI. And how do we treat it? CPAP may reduce the AHI, but it's not really effective. So we think about ASV, we think about BiPAP, especially you need to have the spontaneous time. Of course, can you get them off the opioids? Easier said than done. And the other type of central sleep apnea are those who have a low CO2. They're hypocapnic or eukapnic, and they have an increased ventilatory response. What is on my differential? It could be treatment emergent central sleep apnea. I'm very specific about calling treatment emergent central sleep apnea because you can get central apneas from a mandibular advancement device, from the Inspire device, go figure. It could be high altitude. It could be Sheen-Stokes, which we spent a lot of time talking about, and it also could be associated with sleep onset central sleep apnea. And of course, the diagnosis of exclusion is the one we had the huge vignette on, which is going to be the primary central sleep apnea. So when we talk about CPAP-induced central sleep apnea, what is the physiology behind this? So is it going to be people get treatment-induced centrals because there's a high loop gain? I could buy that, you know what I mean? Because you're just blowing off so much CO2. I like that. Is it C, because they're not used to, someone putting a CPAP right on their face and they're kind of anxious and blowing off the CO2? I kind of like that too. Or is it B, something called the Herring-Brower reflex? And I know what you're thinking out there. You're like, well, I can't believe Dr. Raj is, pimping us. And he's already over time. It's already 1 hour and 20 minutes. And he's talking about Herring-Brower. Sorry about that, everyone. But the answer is, I got to talk about it. And the answer is yes. So it's going to be all of the above. So what is the Herring-Brower reflex? So how do I just kind of super simplify it? Remember, if you look on the right, on this side over here, is that inspiration is always an active process. And how do we breathe? It's in the brainstem, midbrain, pons, medulla. You get signals that send through the phrenic nerve down to the diaphragm. It goes down, increased AP diameter, and air is going to flow from the atmosphere into the lungs. And what happens is this air flows, and remember, flow means volume over time. As volume is coming into the lungs, you're going to open up the airways. But remember, when we talk about breathing, there's something called the apneutic center, which is a center that's a continuous stimulus to take a breath in. It's always firing to take you to take a breath in. So there's a point when you're breathing in that you gotta stop breathing in or you're just gonna blow up the lung, So what happens is this air is flowing from the atmosphere into the lung. There are stretch receptors in the airways that sense like, oh boy, too much volume is coming in. It sends a signal, a reflex, to the pneumotaxic center to shut off the apneutic center so you won't take that breath in. It shuts off. And that reflex from the stretch receptors in the airways to the pneumotaxic center is called the Herring-Brower reflex. And this makes total sense because why does it associate with central apneas? Is because these individuals are not breathing through negative pressure respiration. They're suddenly put on positive pressure. And what's happening is that I'm blasting air into the airways. It's stretching it out. And the more you start cranking up the CPAP or the BPAP, the more stretch is on those airways. And you're inducing that Herring-Brower reflex to stop breathing. So that's going to be a great one for your board exams. So I put these 4 bullet points here to get some more points on your boards. 5 to 15% of patients with OSA will develop treatment emergent central sleep apnea. 85% of treatment emergent central sleep apnea will eventually just go away by sticking with CPAP itself. You could consider a trial of ASV if the central sleep apnea persists on CPAP or they're not stable on the CPAP. And treatment emergent central sleep apnea can definitely occur from dental devices, ENT surgery, from the Inspire. They can do it also. That's why we use the terminology treatment emergent central sleep apnea. And central sleep apnea treatment is definitely not standardized. The answer is always treat the underlying cause. If it's someone with CHF, make sure they're on mortality reducing drugs. We call that GDMT, goal-directed medical therapy. Make sure they're on things like their SGL2 inhibitors. Those are new diabetic drugs, beta blockers, things that will affect the renin-angiotensin system. That new drug, the nacilliprin inhibitor, brand name Entresto, all these things will go into it. And then, of course, we think about non-invasive positive airway pressure. You could think about CPAP plus or minus oxygen, BiPAP with a backup rate. And of course, the biggest thing is ASV, not for CHF. And there's so many new studies coming out. I know that the classic studies were kind of separating Respironics and ResMed and all these different things. There's newer studies coming out. But still, for the boards for this time, I would say that if someone has a lower EF, I would probably not use ASV at this time. But of course, there are certain times where you may consider it on a case-by-case basis. We spoke about nocturnal oxygen. Of course, the big one right now that's non-invasive is is invasive, but not a mask, is something called a phrenic nerve stimulator. It goes by the brand name Respicardia. It actually stimulates the diaphragm, go figure, one of the diaphragms, to actually be contracting to help you breathe when you have central sleep apnea. And there are medications out there too. Some of these are a little old school. Things like acetazolamide, a carbonic anhydrase inhibitor, which induces a metabolic acidosis to help you develop a respiratory alkalosis. And medroxyprogesterone is a direct respiratory stimulant, though not commonly used in our patients. And I put this here. One of the hypoventilation syndromes is congenital central alveolar hypoventilation syndrome, otherwise known as Odine's curse. And I put the bullet points that they'll ask you on the board exams, which is this is a failure of autonomic control of breathing. There's diminished response to O2 and CO2. Even though the onset's in infancy, it still can occur later in life. And at times, it gets triggered in adults after they get anesthetic. So look for that kind of pearl right there. Clinically, these patients have normal respiratory rate with very, very low tidal volumes. And, I always say, unfortunately, there is some memorizing on the boards. So one of the mutations they're definitely going to ask you is the FOX2B gene, the PHOX2B gene. Please know that on your board exams.